I'd like to talk about our liver, if we can. Yeah, thank you. Okay, so our liver is indeed our hard-working organ. Some people even say that it's our hardest working organ, located beneath our rib cage on the right-hand side of our body. The liver has about 500 functions, but the two most important jobs are cleaning or filtering the blood and aiding digestion. The liver regulates most chemical levels in our blood and excretes bile, which helps carry away waste products from the liver. All blood leaving the stomach and intestines passes through the liver, and our liver processes this blood and metabolizes fats, drugs, alcohol, and other toxins. As you can see from the slide, our liver has an important role in regulating hormones, converting carbs to glucose, and storing vitamins and minerals in our body for use. Next slide, please. Okay, so we'll have a brief overview of liver diseases. Who is most at risk of liver disease? So people who are overweight or obese, who drink extensive amounts of alcohol, generally over a long period, people who have hepatitis B or C, people who have problems with their immune system, and people who are born with liver disease, which is not common. In terms of liver diseases, fatty liver disease is becoming more and more common in Australia. And in fact, quite astoundingly, 1 in 3 people in Australia have fatty liver disease. So this is where fat accumulates in liver cells and can gradually damage the liver over time and can cause serious complications such as hepatitis or inflammation. And over a lengthy period can cause cirrhosis or severe scarring of the liver. Some people will have liver cancer, not all, of course, not very many, but it can develop to that extent. The fat that accumulates in the liver can come from other parts of our body. It can come from our intestine, for example, or the liver loses its ability to change the fat into a form that can be eliminated. So fatty liver disease can go undetected for many years, and it takes a long time for damage to occur. However, it's always good for people to have tests if they are at risk. So fatty liver disease includes alcohol-related liver disease, or ARLD, and non-alcoholic fatty liver disease called NAFLD. And in fact, non-alcoholic fatty liver disease is the most common form of fatty liver in Australia. So NAFLD is an umbrella term that covers the accumulation of fat in the liver cells, which sometimes progresses to swelling, fibrosis, and cirrhosis. So a diet high in carbohydrates, sugar, fats, and processed food increases the risk for people of developing NAFLD and can be successfully managed with healthy diet and healthy lifestyle. NASH, or non-alcoholic steatohepatitis, occurs when the liver becomes inflamed and takes place or occurs in the advanced stages of NAFLD. So NASH is associated with obesity, diabetes, and all the elements of metabolic syndrome. Other liver diseases include or result from viral hepatitis, and Pearl and I will be speaking about hepatitis B and hepatitis C in our presentations. So viral hepatitis is inflammation of the liver. Liver cirrhosis is severe scarring of the liver, and it takes years for that condition to take place. Not everyone who has a liver condition will develop cirrhosis, but for people who have liver conditions that are untreated, they're at greater risk of developing cirrhosis years down the track. Liver cancer, of course, not everyone who has liver disease develops cirrhosis, develops liver cancer rather. Not everyone who has cirrhosis develops liver cancer. However, that is a condition that we're seeing more of in Australia. So liver cancer, or people at greater risk of liver cancer, are those who have hepatitis B or hepatitis C, who have fatty liver disease, and liver cirrhosis of any other cause. Genetic and autoimmune diseases are inherited forms of the disease that can cause the liver to undergo metabolic abnormalities, but most of these conditions are very rare. We have a picture there of the stages of liver disease. It can take a long period, years, even decades, for liver disease to progress to the more serious end, and the time taken varies between different people, so it's not the same for everyone. And not everyone develops the most severe form of liver disease, but for anyone with a liver condition, it's recommended that they are monitored regularly. Okay. In terms of the global context, as you can see from the slide, very significant numbers of people die each year from viral hepatitis, and that is in fact a lot more people than who die from HIV/AIDS or malaria. And I think that's not quite as well known. I think HIV/AIDS and malaria get a lot more publicity. We hear about that more than we do about viral hepatitis. NoHep is an international organisation that aims to eliminate viral hepatitis around the world. In Australia, so closer to home, there are around 340,000 people who are living with hepatitis B or hepatitis C, and an estimated 200,000 fewer people received hepatitis screening compared to the expected number in 2020, a 20% decrease, and most probably from the effects of the pandemic, people not reaching out so much for healthcare. Okay. So what is hepatitis? Hepatitis is inflammation of the liver. Hepa is a word from the ancient Greek meaning liver, and titus, inflammation. So hepatitis has a range of causes, including excessive use of alcohol, some chemicals, drugs and medications, and their interactions can cause hepatitis or inflammation of the liver, fatty liver disease, which we've discussed, autoimmune disease, which is rare, but viral hepatitis, hepatitis A, B, C, D, and E, are viruses that cause inflammation of the liver. The ones of main concern to us are hepatitis B and C. Hepatitis A, generally people who have hepatitis A and the route is fecal to oral, generally recover without need of medical help. Hepatitis D is only present in people who have hepatitis B. So not everyone who has hepatitis B gets hepatitis D, but people need to have hepatitis B before they can get hepatitis D. Hepatitis E is very uncommon in Australia. So Pearl and I will be focusing more on hepatitis B and E. For a lot of people, or most people who have viral hepatitis, particularly hepatitis B and C, they don't necessarily notice the symptoms. Some of the common symptoms include tiredness, lack of appetite, which can be put down to a lot of other things. So people wouldn't necessarily recognise those as being from hepatitis. And not everyone has symptoms. So most people, in fact, don't have symptoms. A lot of people, or some people, will call viral hepatitis a sleeping condition or sleeping disease, because it takes many years for damage to take place if people aren't tested or treated or have their condition monitored. So it can catch people unawares after a period of years. Okay. Hepatitis B. So hepatitis B has been around for a long time, and quite astonishingly, about a third of the population in the world has been infected with hepatitis B at one point or other in their lives, which I find really astounding, an astounding kind of statistic. And in Australia, it's estimated that a quarter of people living with chronic hepatitis B have not been diagnosed, probably because they haven't recognised any symptoms if they've had any, and they're just not aware of their condition. So in terms of who is at most risk, there are particular populations at greater risk than others. These include migrant and refugee communities, especially from the Asia Pacific and the Middle East, people from the Mediterranean and Sub-Saharan Africa, where there are large numbers of people living with Hep B, infants and children born to mothers who have hepatitis B, Aboriginal and Torres Strait Islanders, men who have sex with men, people with multiple sexual partners, people who inject drugs or who have ever injected drugs, sexual household and family contact with people living with hepatitis B, sex workers, health professionals who perform exposure-prone procedures, people in custodial settings or who have ever been in a custodial setting, hemodialysis patients, people living with hepatitis C or HIV, and also people who had blood transfusions prior to 1990 in Australia. From that time, the blood supply was screened. And people who have had blood transfusions or procedures in other countries where blood has not been screened or where instruments have not been sterile. So that still takes place in some cases overseas. People who have not received their hepatitis B vaccinations and are not immune are also at risk of hepatitis B. So perhaps we'll move to the next slide. So acute versus chronic. Acute hepatitis, after a person has contracted hepatitis B, the acute phase is for 6 months or so. And if a person is not able to spontaneously get rid of the hepatitis B virus during that time, they go on to have chronic or life-lasting hepatitis. So if a baby has hepatitis, they are most likely to develop a chronic condition, have a lifelong condition unless they receive a vaccine. Adults, however, have a higher chance of eliminating the virus if they contract the virus when they are an adult. So very important for babies to have vaccination immediately after birth. Okay. Transmission. So hepatitis B is a blood-borne virus, meaning that it's transmitted through the blood of a person who has the virus entering the bloodstream of another person. Unprotected sex is also a way that hepatitis B can be transmitted through exchange of female and or male sexual fluids entering blood. And mother to baby is extremely high risk where mothers have hepatitis B. This slide goes over the steps involved in testing for hepatitis B. This graphic is included in packs, and I'm sure our doctors who will be coming a little later would be happy to answer any clinical questions that you might have. So there are 3 tests required. The first being for hepatitis B surface antigen, which shows whether a person currently has hepatitis B infection. Secondly, a test for the hepatitis B core antibody, which will show whether you've ever had hepatitis B, so ever been exposed to the virus. And thirdly, for the hepatitis B surface antibody, which shows whether you're immune to hepatitis B from either having had a previous infection and clearing that, or from immunisation. Okay. Vaccination for hepatitis B. All babies in Australia have been offered the hepatitis B vaccine since the year 2000. It's a course of 3 doses for babies, and it's vitally important that a baby born to a mother who has hepatitis B is offered the first of their vaccinations as soon as possible after birth. That way they have a 95% chance of not going on to develop a chronic condition. So the vaccines are incredibly effective and are available in Australia. So we're lucky in that respect, but very important that babies are given that initial vaccination along with immunoglobulin as immediately as possible after birth. Adults can also receive the vaccine if they haven't been vaccinated before. There are catch-up vaccinations available. It's a 4-vaccine course for adults, and adults should be tested prior to vaccination just to see whether they are immune, whether they may have contracted hepatitis B and are living with it, or whether they may have been vaccinated before and not realised that. Vaccines are free for a number of groups in Australia. They're free for all children and adolescents up to the age of 18 by memory, and for particular population groups, including Aboriginal and Torres Strait Islander people are eligible for free vaccines. Also refugees and asylum seekers who don't have a Medicare card. Right. There's not a cure for hepatitis B. There's no cure at this point. There is medication available, antiviral medication available for people who require it. Not everybody who is living with chronic hepatitis B requires antiviral medication if their immune systems are suppressing the level of virus in their bodies. But if this is not the case, antiviral medication can be very helpful and can reduce the risk of developing, serious disease and cancer as well. It's really important that regardless of whether someone is receiving antiviral medication or not, that they have their condition monitored, given that people's viral load can change over time. So it's recommended that people have 6 monthly checks with their doctor. Okay. So that brings me to the end of talking about hepatitis C, and Pearl will now, B rather, and Pearl will talk about hepatitis C.
Thanks, everyone. Hi, everyone. I'm Pearl, and I'm the Health Promotion Knowledge Officer at LiverWELL, and we're running a bit behind, so I'll do my best to summarize this as briefly as possible. So I'll be talking to you about hepatitis C today, and then we'll have a quick slide on COVID-19 and the effects on hepatitis and liver health. So more than 60% of Australians living with hepatitis C remain untreated. And in Victoria, more than 40,000 people are living with hepatitis C. We have more regarding these numbers, updated numbers from Jen later on in the session. So who is at risk of hepatitis C? Some of these, previous slide, yeah. Some of these populations are overlapping with the ones that we heard from Kay with Hep B. But at-risk populations include injecting drug users, incarcerated persons or people in prisons, We have mother-to-baby transmission. However, the risk with hepatitis C, the risk is a lot lower as compared to hepatitis B. We have recipients of blood transfusions, like Kay mentioned earlier, prior to February 1990, when the tests for screening for Hep B and Hep C weren't introduced. And we have contaminated or inadequately sterilized instruments, needles, common with backyard tattoos and procedures overseas. We also have people who've migrated from endemic regions. You have Southern Europe, Africa, and the Asia Pacific. And Aboriginal and Torres Strait Islander people are 10 times more likely to be diagnosed with hepatitis C as compared to the non-Indigenous population. Next slide, please. So a bit about disease progression here and why it's still a public health challenge in Australia. So as Kay mentioned, there aren't too many symptoms, and the symptoms are often confused with general illnesses. So in the acute phase of infection, the infection stays in your body for about 6 months, and 25% of people will actually cure acute hepatitis C on their own. And research actually shows that women are more, they can clear the acute hepatitis C infection much faster, and they have higher rates of clearance as compared to men. And this is to do with the presence of the hormone estrogen. And any infection that lingers in the body beyond 6 months will go on to develop into chronic hepatitis. And in about 75% of people who don't clear the virus with acute hepatitis C, it'll progress to chronic forms. And if not checked in time, it can progress into liver cirrhosis and fibrosis, where you have scarring and damage in the liver. And in about 25 to 30 years of progression, liver disease progression, you can get hepatocellular carcinoma or liver cancer, followed by end-stage liver disease and even liver failure and death. So before we move on to the next section, I'd like to state that the progression of hepatitis C infection actually varies from person to person. And these are based on a number of factors like age, the person's own genetics, even the genotype of the virus that they're infected with, and even drug and alcohol intake habits. Next slide, please. Elaine, can you click the next button again? So like hepatitis B, hepatitis C transmission also occurs blood to blood. And the pictures here, they're common for hepatitis B as well, but we'll divide them into high risk, intermediate risk, and low risk. So we'll start with the high risk routes of transmission for the virus. You have sharing injecting equipment. That is not just the needles, but also the other equipment used in injecting. You have the tourniquets, the swabs, the filters, the spoons. They have the capacity to be cross-contaminated and establish that transmission route for the virus. Then you have unsterile tattooing and piercing, which is also a high-risk route for transmission of the virus. So any scarification process that involves contact with blood and penetration beyond the skin, there is that risk of transmission with hepatitis B and hepatitis C. And next, we'll talk about sharing snorting equipment, which has an intermediate risk. And this is because our nasal membranes are quite delicate. And sometimes during snorting practices or snorting drugs, you may injure these delicate nasal membranes, and there may be a potential blood-to-blood contact when you're sharing the same equipment. In terms of sharing grooming items, it is recommended that people living with hepatitis B and C have their own personal grooming items like nail clippers, your razors and toothbrushes, and it's recommended they don't share these items with other household members. In terms of workplace exposure, specifically needle stick injuries, there is an intermediate risk, I'd say. The risk is approximately 6%. And again, there are a number of factors at play here. It would depend upon the size of the needle and the depth of penetration, but it is recommended that all health workers be vaccinated against hepatitis B and hepatitis A. Now, with mother to baby transmission, as opposed to hepatitis B, which is highly transmittable from mother to baby, when it comes to hepatitis C, the risk is, again, approximately 6%, but it jumps to about 30 to 40% if the mother is co-infected with HIV. And this is because the virus does not pass through the placenta during pregnancy. The only risk of transmission is during delivery, when there is the chance of contact with mother's blood and the baby's blood. Next slide, please. So this is a slide just to bust the common myths about hepatitis C transmission. So mosquitoes cannot transmit hepatitis B or C. Sharing food, sharing utensils cannot transmit hepatitis B or C. Holding hands, kissing, using public toilets, you can't get the virus. Neither can you get it through, you can't pass it on to the baby through breastfeeding. The only caveat here is that if the mother has cracked nipples, then it's advised that she hold off on breastfeeding and speak to her GP or her healthcare provider. Next slide, please. Okay, so we've spoken about all the transmission routes and we've discussed their associated health impacts. Now it's important to discuss prevention with hepatitis C because we still don't have a vaccine. So we need to look at other ways we can cut down transmission and break that cycle. So we'll start with needle and syringe programs. And we all know that needle and syringe programs are they're a key step in driving down those infection numbers. So in terms of where people can go to access these services, raising awareness about how these services can help, encouraging harm reduction practices, they're a key way in which we can cut down our hepatitis C transmission within the community. Then we have education, like the event we're doing today, it's mainly to raise awareness about transmission, break down the myth and reduce stigma and discrimination regarding the virus and people living with the virus may face. In terms of treatment as prevention, I'll briefly touch upon what this principle implies. So this principle basically states that the more we treat people living with hepatitis C in the community, the more we break this cycle of transmission and drive down those infection numbers. Now, we aren't there yet in terms of meeting our WHO targets in 2030, eliminating the virus, but it's a good principle if you're thinking about our future targets and meeting them, potentially meeting them in the future. And lastly, we have universal precautions, treat every person as infectious. Now, this statement has several nuances. So the first, in healthcare settings, we know that a lot of people face stigma and discrimination. So it's important that we treat every patient the same way and we don't discriminate based on their hepatitis status or their HIV status. So it's important that we follow infection control procedures for each and every patient. And also with COVID in the picture, we know that other measures like hand hygiene, wearing PPE, and autoclaving equipment that can't be disposed, these are already commonly being practiced and they do their own part in cutting down transmission. Other ways we could prevent hepatitis C would be preventing backyard tattoos. And another example I'd like to state is that in Victorian prisons, bleach is provided, and that's a lot more effective in killing the virus as opposed to using soap and water. Next slide, please. Can you click the next button again? So with testing and diagnosis, as Kay mentioned earlier, a lot of people don't know they have the virus. So with 1 in 5 people with hepatitis C, they don't know they have the virus. And the only way to find out is to get the blood test. Now, I'll quickly summarize the 2 tests that people usually get. The first one is the antibody test, which is purely a screening test. And this test will tell you if you've ever been exposed to the virus. So it'll just test for the presence of the antibody in the patient. And if this comes back negative, there are no further tests required. If it comes back positive, you'd have to follow up with the next test. Now, with the first test, there are certain key points to remember. It has a window period of 3 to 6 months. And just because you test positive to these antibodies does not mean you actually have the virus, because earlier I mentioned 25% of people can actually cure acute hepatitis C, and that population would actually still test positive to this test. So they would still have the antibodies, but that doesn't mean they have a current infection. So it's important to have the next step in order to confirm the diagnosis. Another important thing to note with hepatitis C is that the presence of antibodies does not mean you have immunity to the virus, because there are different genotypes of the virus and you can get reinfected. So we'll move on to the next test, which is a confirmatory test, the PCR test, which stands for the polymerase chain reaction. And this test confirms if someone has a current infection. It has a window period of about 2 to 6 weeks after suspected exposure. And it basically tells you a number of things. It'll tell you about the viral load. It'll tell you about the genotype of the virus. And on our liver line, we usually hear that people don't get the second test. They usually get the first test. So it's very important to make sure that people are getting both the tests done in order to confirm their status. And lastly, some liver function tests can be recommended. You have some blood tests that might be done as part of the liver function tests. You have an ultrasound imaging called the FibroScan that is done for screening for liver cirrhosis, fibrosis, and scarring. Next slide, please. So we'll talk a bit about the treatment, and later in the forum, we'll do a deep dive into treatment. So the rate of treatment uptake has declined steadily since 2016. In Victoria, the 40% decline that was noted in 2020 has been attributed to the pandemic. And this data was released last year as part of a media release from Hepatitis Australia. So some pre-assessments are usually done to determine the best course of treatment. And these are usually virological evaluations to just screen the patient beforehand in order to prescribe them the best course of medication. A bit about the old treatment before we talk about the new drugs that are available. So interferon therapy was done earlier, which is like chemotherapy with ribavirin. And this was actually a pretty harsh treatment with troublesome side effects. And luckily, we have these new drugs that are very easy to take, and they have 95% success rate. They've been available since 2016. And they're also available subsidized on the Australian Pharmaceutical Benefit Scheme. Now, they include pills that are taken daily for 8 to 12 weeks, sometimes 24 weeks. And it's recommended that people complete the entire course of medication to see the full effect. And the commonly prescribed drugs are Epclusa, Mavorrat, and Harvoni. Next slide, please. So a bit about eligibility and restrictions. So regarding the eligibility on accessing treatment, everyone can access treatment, whether they're using drugs, whether they're on an alcohol rehab program. And it usually also works if people have significant liver damage, because it's still recommended because these drugs still work quite well, even if the person has fibrosis or liver cirrhosis. Now, the only restriction is that the DAAs are not recommended if the person is pregnant or breastfeeding. Now, barriers to treatment and supporting clients. So the common barriers to treating and supporting clients would be so the treatment is still out there, but the news hasn't gotten around yet and the uptake is quite low. And the common barriers we get based on the liver line information that we receive at LiverWELL is that there are competing priorities with drug and alcohol services. Then there's stigma and discrimination that people face while accessing healthcare. There are systemic and structural barriers as well, and also misinformation about the cost and eligibility of drugs. Now, in terms of how the person knows whether they've cured the virus, we'll have the doctors telling us a bit about this in detail later, but I'll just touch upon them. You get a PCR test 3 months after you complete the treatment, just to check your sustained virologic response. And if this test comes back negative, it means that you've successfully cleared the virus. In terms of monitoring hepatitis C, as I mentioned earlier, there are different strains of the virus. So there are various genotypes. In Australia alone, we have 6 different genotypes. So it is possible you can get reinfected. So it's very important to monitor your condition constantly. And the good news is that you can access treatment and there's no cap on the number of times you can access the treatment. Next slide, please. So with that, we wrap up hepatitis C. We'll quickly browse through COVID-19 hepatitis and liver health. So liver being the chief metabolic organ in our body, it has faced a lot of effect from the COVID-19 vaccine. So some people with COVID-19 have reported abnormal liver function and liver injury, especially people with liver conditions like hepatitis or fatty liver disease. They have reported poor health outcomes following COVID-19 infection. Also, hepatitis screening and treatment uptake has seen to decrease because of the pandemic, especially in the harder hit states in New South Wales and Victoria. And lastly, it is important to encourage self-care and address lifestyle factors. LiverWELL has worked on 4 lifestyle guides on eating well, getting active, feeling well, and being drink aware. And if you're interested in looking at these resources, you can hop onto our website or meet us after the session, and we have them at our information desk. Next slide. And just to summarize what we've covered till now, K and I, so there are significant rates of viral Hep B and hepatitis C in Australia. Both have an acute and a chronic phase. There is a very effective vaccine for hepatitis B, and there are effective cures for hepatitis C, but we still don't have a vaccine yet. And with that, we come to the end of this session. And if you'd like to contact us, our contact details are on the next slide. Thank you.